Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening. We are continuing on today with the top 200 drugs list. We're going to look at Prednisone, Ezetimibe, fish oil, Raloxifene, and Phenytoin. So hopefully those drugs will keep you interested. Got a lot to cover on Phenytoin and Prednisone specifically. Lots of details there, things that could come up on your board exams and your pharmacology exams throughout college. So with that said, I want to remind you, please support the sponsor, med101.com/store. All your purchases there on Amazon books, other study materials, review courses, all that goes to support this podcast, help keep it free and available for all to benefit from. So again, all your purchases there, med101.com/store. Go check it out, support the sponsor, and support this podcast as well. All right, so let's get into the drugs today. And we've got number 41. Let's start with Prednisone. Brand name of this medication is Deltazone, and this is a corticosteroid. You're going to see it used a lot in practice. I've seen it used a lot in practice, and it's mostly used shorter term basis for inflammatory type conditions. Also maybe analgesic type conditions as well. So, for instance, gout, rheumatoid arthritis, flares of those disease states where you have a high degree of inflammation as well as pain that's associated with that inflammation. Those are definitely common uses of prednisone. Other conditions where we've got some inflammation involved, potentially asthma, COPD exacerbations, dermatitis, skin reactions, those type of conditions as well. So, again, lots and lots of utilizations for prednisone. You're going to see it used for lots of different inflammatory disorders. That's just the tip of the iceberg and the common indications that I see it used for on a somewhat regular basis. In addition, I did want to mention prednisone can be used for immunosuppression purposes, so an organ transplantation, things of that nature. It can also be, or is shown to be somewhat helpful in reducing nausea. Corticosteroids in general have been shown to kind of help with nausea symptoms as well, and things like that. All right, so let's discuss adverse effects a little bit. So first and foremost, I want to talk a little bit about the kind of short-term immediate adverse effects you're going to see, good ones to educate the patient on. GI upset, stomach issues, can increase ulcer risk. It's recommended to administer prednisone with food and or milk, and that's going to help potentially reduce the risk or the incidence of some of those GI adverse effects. Other kind of acute short-term adverse effects, it can tend to ramp people up a little bit, so you can definitely have some insomnia. So we like, if you've got let's say 20 milligrams of prednisone for 5 days, we'd like to give that prednisone earlier in the day if possible. So sometimes, patients come into the clinic, they get prescribed it at, 4 or 5 p.m., they get to the pharmacy at 6 or 7, depending upon what the situation is and how quickly we want to get that prednisone started. You may give it in that situation, but obviously we definitely want to educate our patients, like this may keep you up a little bit at night. So ideally, the earlier in the day that we can take it with food is generally the better. So also associated with that insomnia, some people will get a little bit more anxiety. So if you have a patient that's really prone to that, definitely something to be aware of and pay attention to. A few disease states I wanted to mention to maybe be a little bit careful with, or at least a little extra monitoring or patient education. So first and foremost, diabetes. Prednisone can increase blood sugar, and all corticosteroids can increase blood sugar, cause that hyperglycemia, and really throw patients out of whack. So patients taking insulin, for example, I've seen some issues with that. where patients have adjusted. Let's say they've got a 5-10 day course of prednisone. They've adjusted their insulin dose because they've seen their blood sugars go higher. And then when that prednisone stops, then their blood sugars go back down to normal and they may get hypoglycemic. So educating patients maybe to monitor those blood sugars a little bit more closely. And if you've got some mild to moderate spikes in blood sugar, that's maybe not, a huge deal. But just keep patients aware that have been, very well controlled. They may see those spikes and those big fluctuations. Heart failure is another one to pay attention to. It can increase risk for signs and symptoms of heart failure in those type of patients. Blood pressure as well. It can bump blood pressure up a little bit. So pay attention to that too. The long-term adverse effects of prednisone, more so if you're taking it on a chronic basis, which again is why we try to limit the use if we can. So we can have, that immunosuppression risk. The longer they're on it, the higher the dose. That can increase that risk for infection and things like that. HbA suppression, that's really probably one of the biggest primary reasons why we try to limit its use to, 1 week or less than 2 weeks. And then osteoporosis as well is a common long-term adverse effect if you've got a patient who's taking it chronically. All right, next medication, number 42, is Ezetimibe. Brand name of this medication is Zetia. It is a cholesterol agent. It is primarily focused on reducing LDL. Now, mechanistically, how does it do that? It inhibits gut absorption of cholesterol by impacting Niemann-Pick C1-like 1 transporter, abbreviated NPC1L1. So Niemann-Pick is kind of the thing that I always remember associated with that. And if you're taking exams or preparing for exams regarding hyperlipidemia or board exams, that's probably the big thing to remember from a mechanism standpoint, if you're required to remember that. Where do we see this used so it lowers LDL? Like I mentioned, it's typically added on to statin therapy. But you may see it used as kind of an alternative if you've got a patient that's tried numerous statins and they can't tolerate them for whatever reason. You may see Ezetimibe used as monotherapy. Probably the biggest downside compared to statins is it's just not as potent. Tolerability is there. It's not bad that way. But it's just not as near as potent at reducing LDL and reducing cardiovascular risk compared to the proven efficacy and benefit that we have with statins. So just to give you an idea here, it's in the neighborhood of 15 to 20% reduction in LDL. Maybe it can get slightly higher than that, but versus statins, you can get above 50% reduction in LDL with statin therapy. So again, just not quite as potent, generally well tolerated. So from an adverse effect standpoint, I don't typically worry a ton about side effects with this medication. You may see some GI adverse effects reported. I would say it's pretty low. And then I have seen reports of myopathy as well. That's probably more likely in patients who are taking statin therapy already. With 43, we're going to stick on the cholesterol theme. So we've got fish oil type products, Lovaza being a brand name product there. So these are omega-3 polyunsaturated fatty acids. Mechanism of action isn't totally well understood, but ultimately helps kind of blunt the liver, the production of triglycerides and liver production of triglyceride-rich LDL. VLDL is what I should say there. So ultimately, the use of this is patients with hypertriglyceridemia, so elevated triglycerides. We're trying to reduce those. Now, in most patients, we focus on LDL first, but if you've got somebody with substantially high triglycerides and they're at risk for pancreatitis, then we might focus on those triglycerides first and potentially consider a medication like fish oil. Adverse effect profile, usually GI upset's probably the most common there. Sometimes these pills can be larger, so from an adherence standpoint, from an administration standpoint, that may be challenging for some patients. We can get some burping and fishy type taste depending upon the product as well a little bit there. There is a theoretical risk on platelet function. I don't worry about it to a tremendous extent, but it is out there in the literature a little bit. So I guess it's something to consider if you've got a patient that's, severely anemic or they're reporting bruising and bleeding. It might be something to look at and consider and reassess kind of that risk versus benefit. I did want to differentiate Lovaza a little bit from Vascepa. So Vascepa is, again, kind of a similar type product, but it does have evidence in lowering ASCVD risk compared to Lovaza, which does not have that demonstrated benefit, at least from the literature I've seen. So kind of one differentiating thing there with Lovaza compared to some of the other fish oil type products. All right, moving on, we've got to number 44. We've got Raloxifene. Brand name is Evista. This is a SERM type agent, so the SERM. That stands for Selective Estrogen Receptor Modifier. So essentially, what this does is it stimulates specific estrogen receptors in bone and also can act as an estrogen antagonist as well. So we've certainly got an indication for osteoporosis, where again, more estrogen you have, the better it is for bone health. This is why postmenopausal women with less estrogen tend to be at greater risk for osteoporosis. But then it's, selectivity and what it does with estrogen receptors. It can act as an antagonist at other sites and potentially be useful in certain types of breast cancer as well. So kind of a dual indication with this. For osteoporosis, Raloxifene is not considered a first-line agent. It's kind of more along the lines if somebody can't tolerate, let's say, an oral bisphosphonate like alendronate. For whatever reason, Raloxifene may come into play as a potential alternative there. And then obviously if you've got the two birds with one stone, where it's beneficial for oncology purposes, and using it in breast cancer, we can have that beneficial effect of osteoporosis management there. So if we can do that, that's certainly a great thing. With that said, just kind of in the osteoporosis realm here, reason why it's not utilized first line for osteoporosis is we've got a risk of adverse effects, but we've also got lower efficacy than some of the other agents like bisphosphonates and denosumab, for example. Those adverse effects, let's touch on that a little bit here. One of the biggest things that I look out for is risk for clot, so DVT and stroke. That risk can increase with the use of Raloxifene. So that's something to look out for if you've got patients, who are taking anticoagulation and you see that they have that clot risk. Raloxifene probably isn't a great medication to utilize in that patient population if we can avoid it. So definitely pay attention to that. And then with some of the estrogen blocking activities, it kind of has, again, it's kind of selective on which estrogen receptors it's hitting and which ones it's not, which ones it's, agonizing and which ones it's antagonizing. With that said, it has been reported that you'll see some hot flashes with Raloxifene, so that can be challenging for some patients there as well. All right, and we are moving on to the last medication. It is Phenytoin. Brand name of this medication is Dilantin. As far as mechanism of action, It is an anti-seizure medication, and it's thought to do this by the inhibition of voltage-gated sodium channels. Mechanism isn't totally well understood, but that's the proposed, most commonly proposed mechanism with phenytoin. All right, so utilizing it for seizures, what adverse effects are we going to encounter? So GI adverse effects can happen, CNS changes, confusion, sedation. Ataxia is a good one to remember. So kind of that difficulty walking or stumbling. If you notice changes in a patient's gait, that may indicate that they've got some signs and symptoms of toxicity. It can actually induce the metabolism of vitamin D. So it can lower vitamin D levels and cause some deficiency there. So supplementation may be needed there. There has been issues reported with liver function changes. It's on the rare side, but that definitely has happened there. Drug interactions. I definitely want to mention this with phenytoin. There's lots of them, and that is a big challenge with phenytoin. So a few examples of meds that can increase concentrations or potentially have some additive adverse effects. Fluconazole, amiodarone, alcohol, cimetidine, fluvoxamine. These are all likely to increase the risk of toxicity or symptoms of toxicity there. In clinical practice, dilantin or phenytoin is one of those that scares me a little bit. And so if we have a new medication that's starting and I see somebody on phenytoin, that definitely prompts me. That's a good time to take a peek at their medication list, maybe run a drug interaction screen, and make sure nothing's going to mess with that phenytoin level, because remember, phenytoin is a narrow therapeutic window drug. So that is a really, really important thing to remember. Basically, what that means is there's really a small drug concentration, a small window where that drug concentration can fall that's therapeutic in preventing seizures, but not toxic in causing adverse effects. So that is definitely a challenge there for sure. So that usual phenytoin level is in the 10 to 20 range. This can be a little bit misleading if patients have low albumin. So in those type of situations, a free level is considered best. But you also want to look back, and see what patients' previous levels have been, where that baseline is, and see if there's any trends in escalation, and then obviously the associated clinical symptoms that may appear as well. So phenytoin is highly albumin bound. So if that albumin falls over time, probably the most common situation is older patients with malnutrition. They may have a good example of lower albumin levels. And if that's true, we're going to have a higher free fraction of drug and increase the risk for toxicity, even though the total blood levels may look normal. And so that's why we consider doing a free level in some situations there. Those toxicity signs and symptoms, I kind of alluded to it already in the adverse effects, but that ataxia, difficulty walking, confusion, GI side effects, slurred speech. I did want to mention one other one that I didn't mention in the adverse effects, vertical nystagmus. So this is the kind of unique moving of the eyes, kind of this shuddering or moving up and down of the eyes. So that is something to pay attention to. It's not something I've seen in practice, and I think from the literature it takes pretty high levels to get that adverse effect. But if you happen to see that, you definitely want to go look at that patient's medication list and see if they're on phenytoin, because it's definitely one of the medications that could potentially cause that adverse effect. All right, so that wraps up the next 5 of the top 200 drugs. Be sure to go check out the free top 200 study guide at reallifepharmacology.com. It's a free 31-page PDF where I lay out some of the most important things that you're going to see in practice and that you're going to see come up on pharmacology and board exams throughout your career. So go take advantage of that. Absolutely free, no cost to you, simply an email to get access to that. We also get you updates when we've got new podcasts and other content available as well. So again, do that at reallifepharmacology.com. If you enjoyed this episode, do us a huge favor, leave a rating, review on iTunes or wherever you're listening. Share us, friends, colleagues, listservs, whoever needs help with pharmacology education. It's what I love to do, and I'm grateful I'm able to do it on a daily basis here. So I definitely appreciate all you guys listening and trying to learn and get better at pharmacology. It can get complicated at times, that's for sure. If you got any comments, questions, suggestions, mededucation101@gmail.com. Feel free. If you think I misspoke on something or got something incorrect, I'm definitely not immune from making mistakes, just like the rest of you healthcare professionals out there. So with that said, again, support the sponsor, med101.com/store. Reach out to me, mededucation101@gmail.com. And I hope you have a great rest of your day. Thanks so much for listening.